All right. A very good evening to Professor Jang, Dr. Lehan, for accepting our
Good evening.
invitation, especially the Dr. Jang as the speaker for the day, and Dr. Lehan, a good friend, for moderating the session for the day. And a very good evening to all the participants joining this webinar. Okay, is in Asia is quite late in the evening. It's quite night here. Okay, so today let me introduce Dr. Jang webinar. Okay, which is going to be moderated by Dr. Lehan. Okay, the topic today for is advantages and drawbacks of septal extension graft in rhinoplasty by Dr. Jang. Okay. But before that, maybe let me briefly introduce my good friend, mentor, senior, Dr. Lehan. Professor Lehan, MD, PhD, is a highly respected plastics and aesthetic surgeon in Vietnam with over 4 decades of experience in cosmetic and reconstructive surgery. He is the president of the Vietnam Society of Aesthetic Plastic Surgery, VSEPS, and former president of Ho Chi Minh City Society of Plastics and Aesthetic Surgery, VSEPS. Okay. Professor Lehan previously served as chairman of the Department of Plastic and Aesthetic Surgery at Pham Ngoc Thang Medical University and founder and head of the Plastics and Aesthetic Surgery Department at Chore Hospital. He currently practices as director of Lehan Center of Plastics and Cosmetic Surgery in Ho Chi Minh City and continue to contribute actively to regional and international aesthetic communities. So without further ado, I pass on the baton to Dr. Lehan. Dr. Lehan.
Yes, thank you very much, Eddie, for your nice introduction. Good evening, everybody. And welcome to the webinar of the Nose and Fat webinar. And today, and to learn with the Dr. Zhang Zhang. I'm very happy to be the moderator in this session. Professor Yong Jang is an internationally acclaimed rhinologic surgeon with a particular expertise in Asian rhinoplasty and rhinologic surgery. He has made a substantial contribution to the field through his authorship of the prominent textbooks such as Practical Septal Rhinoplasty and Septoplasty, and has published over 172 articles in peer-reviewed international journals. Dr. Jang research spanned both clinical practice and basic science, notably advancing the understanding of rhinovirus-related sinusitis and innovation in rhinoplasty procedures. Additionally, he has been at the forefront of research and treatment for empty nose syndrome and hereditary hemorrhagic telangiectasia. Please welcome Dr. Professor Zhang Zhang. Dr. Zhang, can I pass
Uh,
the
yeah.
microphone to you?
Dr. Luhan and Dr. Eddie Liu, thank you for invitation. It's my great pleasure to speak about septal extension graft today. I will share my slide. Can you see my slides?
Not yet.
Okay,
Not yet.
no problem.
Yeah.
Can you see?
Not yet.
Not yet? Okay.
Not yet.
Yeah,
Yeah.
I will.
Not yet. You can share it. Yes.
I'll share again. Okay, I'm sorry for that.
No worries.
now can you see?
Yes.
Okay, great. Yeah.
Okay, great. Yeah.
So for about next 40 minutes, I'll talk about septal extension grafts, its advantages and drawbacks. So I'm professor at the Department of Otolaryngology and Assam Medical Center in University of Ulsan College of Medicine, Seoul, Korea. What is septal extension graft? This is grafts fixed to the native septum. The intention is to improve nasal aesthetics and nasal support. There are different ways of placing septal extension graft. It can be placed at those are L strut, or it can be placed at caudal part. This septal extension graft is placed at the caudal septal part like this. And this is end-to-end type septal extension graft. There are many variations. The commonality is that it increased the dimension of the existing septal cartilage, and orientation is also will be changed. So what is the merits of septal extension graft? Unlike the usual teeth grafting, this graft can strengthen the nasal base, strengthen the support. This is a concealed graft, meaning that ultimately this should be covered with ala cartilage. It has really versatile function. When it comes to tip refinement, in Asian rhinoplasty, we usually need to refine the tip, more anterocaudally projected and defined nasal tip. To achieve this goal, what we usually use is a tip grafting like this. So you can make the tip from here to here by adding some tip grafting. So this is typical cases who benefited by tip grafting. So using conchal cartilage, I could better project and better refine her tip from here to here. Sometimes this causes quite obvious graft contour. This look really unnatural. This is another case. I placed tip grafting and septal extension graft, but tip graft ultimately showed up like this. And this is quite obvious contour of the tip graft. So, however, the septal extension graft is usually covered with the ala cartilage. You don't need to worry about this type of graft showing. By applying septal extension graft, you can project the tip, or you can rotate, you can derotate. You can do many things on the tip. For example, in this lady, her tip looks a little bit too thick, so I intended to rotate up the tip using septal extension graft. As you can see, her tip is projected and rotated. So from here to here, it was done by the placement of the septal extension graft, extended spread graft combined with the septal extension graft. It relocated and reoriented the position of the lower lateral cartilage. That's what septal extension graft is doing. In this patient has concave ala lobule here, but I didn't put any lateral coronary graft. Instead, what I did was stretch up this concave ala cartilage. So his ala cartilage concavity is improved only with the aid of the septal extension graft. As you can see, his tip is projected. Another Caucasian lady, similar problem. I didn't do anything particular on the to correct ala lobar concavity. I didn't put any graft here, but instead I just placed a very strong septal extension graft, and it just stretched up the alar cartilage, and the alar lobar concavity is improved. It's very, very useful for correction of nostril asymmetry like this. Actually, this is typical complication of a silicone rhinoplasty. The capsule contracture causes this kind of asymmetric nostril. And in order to correct this, you have to place a very strong midline structure at the coronal septum. So this is illustration showing how it worked. By placement of the septal extension graft, I could balance, I could gain symmetry of the both alar cartilages. In this case, he didn't like this upturned nose, too much nostril show. So to derotate the nose, what we have to place is also septal extension graft. So I could derotate his nose from here to here. This illustration shows how did this extension graft acted to derotate his tip. There are many different ways of placing extension graft on the septum. But today I will introduce you my four preferred septal extension grafting technique. The first one is bilateral placement of the batten type extension graft. The second one is unilateral batten type in deviated nose patient. And the other one is end-to-end coronal septal extension graft fixed with bilateral extended spreader graft. And recently I started using partially overlapping septal extension graft when I don't need to place extended spread graft. So this patient visited me very, very underprojected tip with the hump here. So I harvested costal cartilage because many Asian patients, their septal cartilage is not so strong. So I placed side by side two bilateral extended, bilateral batten type septal extension graft. It's very powerful to gain enough tip projection, as is shown in this case. As you can see, her hump is gone and tip projection is achieved. Another lady who also had a underprojected nasal tip, so I placed two bilateral extended bilateral photoreceptor extension graft. Her tip projection was quite enough. It was quite satisfactory. As you can see, because of the tip projection, now her nose look in ideal shape. So I talk about bilateral photoreceptor extension graft, but sometimes I use the place batten type septal extension graft on one side, especially when the patient has deviated nose. So in this patient, she has deviation to the left side. So I placed side by side unilateral batten type grafting on the right side. The height is more higher than native photoreceptor height. So it's the purpose is to gain the projection. So as you can see here, the deviation is corrected and tip projection was achieved. Another case, in her case, her deviation is toward the right side. So I placed the unilateral batten type septal extension graft on the left side of her coronal septum. It was side by side septal extension graft. So those are the hump is gone and profile line is better. The bilateral extended spreader graft combined with coronal septal extension graft and small piece of the batten here. It's the technique I like to use most because this technique is quite versatile. it can create very stable structure. Unlike the side-by-side septal extension graft, it carries less risk of airway obstruction. You can easily understand why it uh, has less risk of airway obstruction. Um, Technically, this is a little more complicated than side-by-side extension graft because you have to stabilize the extension graft, which is placed end to end to the coronal septum. How I can fix this? You can place a bilateral extended spread graft as shown in this picture. The caudal septal extension graft is fixed directly to the caudal septum. And you can add a little more small batten graft here. There's some misspell. And if you want really strong support fixation, you can further fix this to the anterior spine, and soft tissue around the anterior spine, or you can fix it directly to the bone. So when you have to connect this septal extension graft to the bone, sometimes you can use a towel clip, or you can use drill, and then you can pass needle IU, and then you can have very strong fixation to the coronal septum, anterior spine. As I already mentioned, illustrated, I explained, this can have support from exerted by the extended spread graft. It is also supported by the end-to-end connection, and you can further support right here. So if you execute this technique very well, you can have nice result like this lady. So this was a revision case. I could project her tip quite considerably. It's a big tip projection. Other case, deviation to the right side and deformed nose. So I used bilateral extended spread graft plus caudal septal extension graft. So I could project his nose very well, and those augmentation was also performed. In her case, although she had deviation to the right side, I chose placement of the bilateral extended spread graft plus caudal septal extension graft. I also did some ala-based work. So now, as you can see, those look all balanced. The tip projection is very good. This is a very interesting case. This patient doesn't have any trauma, but his nose tip looks like just amputated. I think the placement of the septal extension graft supported by the coral extended spread graft was really, really powerful way of refining his tip. So I could make his a new tip. Recently, I started using a partially overlapping septal extension graft without extended spread graft. So it says actually this is a combination of side-by-side type batten graft plus one end-to-end type for the septal extension graft. So there is a little bit of overlap, not completely overlap. So this is also a useful technique for tip projection, especially when you don't need to place extended spread graft. So this patient is a typical example who benefited by application of this technique. So whole nose is augmented very well. But there are some considerations you have to understand. When you place septal extension graft, this should be big enough so that it can push up or bring down in wanted position. But if the patient has a relatively big membranous septum, and if the septal extension graft is not big enough, it does not result in any desired effect. So you have to keep this factor in mind. And when we have a desired tip height, yeah, we can design the septal extension graft height in a desired length and height. But the problem is the final tip height should be determined by the additional factors. So if you cannot approximate the lower lateral cartilage well, you have to give up the height of the coral septal extension graft. So shape of the ala cartilage and proper approximation of the ala cartilage, height of the coral septal extension graft, three factors which bring about the final shape and height of the nasal tip. So I placed a very high septal extension graft, but if I cannot pull up and cover this with the ala cartilage, I have to adjust. I have to give up a little bit of height. But in this case, because it's relatively redundant, I could cover it very well. But if it's not that easy to pull the ala cartilage up, you have to do full dissection, lateral dissection of the lower lateral cartilage. So then you can maximally mobilize the ala cartilage. So it's always the determining factor for the final tip height. In some cases, if you cannot pull it enough, what you can do is divide the dome here and then elevate the cartilage. It's like a dome division. So this is a useful technique, especially when the patient has a short nose and severe scar around here. And the other way we can effectively elevate the tip is sometimes you can release the ala cartilage from the underlying basilar mucosa. Then you can have more room and mobility of the ala cartilage. Even with that kind of every effort, if you cannot cover the septal extension graft with ala cartilage, and you still need to augment the tip more, in that particular situation, you can place the shoulder graft, and this exposed septal extension graft can act as a backing graft to support the shoulder graft. And this space, you can feel crushed cartilage or diced cartilage. The next thing I want to talk about is the in some patients, placement of the septal extension grafting alone may not be enough. If the native ala cartilage is too thick, the shape is too much round, unfavorable, you cannot make a desired tip shape only with septal extension graft. In that particular situation, you have to add additional tip grafting to achieve your aesthetic goals. So in this case, I placed septal extension graft and additional tip grafting was used. Another case, similar case, I used septal extension graft and placed additional tip grafting, same story. So if the patient, especially when the patient want quite obvious operator looking higher tip, so sometimes you need both. Sometimes just extension graft alone is not enough. The suitable cartilage for the septal extension graft is a septal cartilage and posterior cartilage, but sometimes we encounter situations where we have to use ear cartilage. But as you know, ear cartilage has a curvature. It's not rigid, it's supple. So in order to overcome the curvature, you can use ethmoid bone, PP bone, and to make some holes. And you can stand this ear cartilage. You can make it straighter. And then you can use this as a septal extension graft. So this is intraoperative view of the bone anchored, bone supported ear cartilage. So in this case, I used the technique I explained to you with the photograph. I mostly talk about the tip projection and the rotation, but applying the septal extension concept can be used for the dorsal extension of the nasal septum so that you can augment the cartilaginous dorsum a little bit. So this technique is explained in my paper in cellulose correction. So if you think that you need to augment the dorsal height, you can place two extended spread graft, which was extended more dorsally, but I recommend you place one graft in between here. I call this gap graft. So this graft will balance this extended spread, dorsally extended spread graft. There will be no splaying of this lower part. So I call this gap graft. One doctor in Russia has published the similar procedures, which I already published. So this patient has a cellulose. So I reconstructed his caudal septum and dorsal septum with caudal extension and dorsal extension, and additional dorsal implant was also used for correct his cellulose deformity. When we apply septal extension graft, the prerequisite is that the native L strut, preserved L strut, should be stable and it should have a reasonable strength. If the L strut is very weak and thin, you have to reinforce this force. Then you have to place septal extension graft. How can we reinforce the L strut? I think the easiest way is using bone grafting, bone taken from perpendicular to a plate of ethmoid. So in this patient, a deviation and hump nose. So I place the bone batting graft on the left side. So I'm reinforcing the strength of the native L strut with bone. And then I place bilateral type batten type septal extension graft. So by this effort, I could make his nose much more straighter and much better projected. From now on, I will talk about drawbacks and complications. Yeah, septal extension graft is a powerful way of achieving ideal tip aesthetics, but you have to understand that there are some problems pertaining to this septal extension graft: nasal obstruction, tilted columella, nostril deformity, tip stiffness, infection, the projection and rotation can be problems. So I found that the placement of the thick coastal cartilage septal extension graft, especially in the revision setting, has high risk of infection. So this patient developed infection. So usually infection manifest as initial sign of the infection is septal abscess or hematoma. If you did a rhinoplasty with many coastal cartilages, big chunk of coastal cartilage, and patient developed this caudal septal bulging, this is emergency. You should not rely on antibiotic to control this. So it's very, very unhappy story of my patient. This patient is from Mongolia, 2 times previous rhinoplasty. So he wanted correction of deviation and columnar and saddle. So I used coastal cartilage. I placed the caudal septal extension graft and extended spreader graft, and I placed hip grafting. About 10 days later, he developed this caudal septal bulging. It was very, very painful decision, but I have to bring him to the operating room, and I opened his nose, and I found all the graft material got contaminated. Tissue material, blood tissue material, and this it was such a painful moment for me and his patient, but it's the best way to control this infection. So after removal, still his nose remains still straight, but the projection I gained initially, I lost the projection. But this is much better than the bad consequence of ill-controlled infection. So you have to give up some aesthetic achievement you already made. So I'm thinking about the way how I can prevent infection. I think that massive irrigation is needed. So I'm using more and more transmucosal suture to prevent this type of infection. And the silenced sheathing is important. And if you can, you better not to dissect the whole septal mucosa. So I think almost all mobility related with the infection related mobility comes from start from the septal mucosa. So this is transmucosal suture. So whenever I place batten graft caudal septal extension graft, I place many transmucosal suture. And if the patient doesn't have deviation, I dissect just dorsally and caudally to accommodate the septal extension graft. Mostly it's coastal cartilage because in my rhinoplasty, to get the substantial degree of augmentation, I always use coastal cartilage. Using coastal cartilage, I elevate the tip and I augment the nasal dorsum. And recently, I started using this technique, a subdorsal extended spreader graft. So I don't separate upper lateral from the septal cartilage. Instead, I just make a pocket and then I place a subdorsal extended spreader graft. This will further stabilize the caudal septal extension graft. Nostril asymmetry and tilted columella is complication which occurs not that it's not so uncommon. Sometimes you have problems like this, especially when you place end-to-end type extension graft. Sometimes it tilted a little bit and then it causes a problem like this. So this patient, I could augment her dorsum tip very well, but she was unhappy about this nostril asymmetry caused by tilted columella. So I had to revise her. And another case, it's my own case. So it was very difficult revision case. Dosum augmentation was acceptable, but later she developed more prominent nostril asymmetry. Actually, it was existing from before surgery, but it got worse. So I had to revise it. I opened the nose and I removed some septal coral septal extension graft and I replaced. Oh, okay. So I removed here and I replaced it on the right side. So by this effort, now her nostril asymmetry is improved. Similar case, mild tilting of the septal extension graft caused nostril asymmetry. So I had to revise it. It's not perfect, but it's much better. If you are not careful enough, this end-to-end type septal extension graft may cause increased columnar show as shown in this patient. Usually, patient doesn't care that much, but some sensitive individuals may complain, and then you need to revise this. Especially when you place side-by-side septal extension graft, or if you use thick cartilage as extended spreader graft, it tends to cause impaired nasal breathing function. So in this case, you can see the high septal bulging. It was because of the thick costal cartilage extended spreader grafting. So, to prevent this problem, you should be able to bevel the color and of the extended spreader grafting. You have to bevel, you have to taper the thickness, and not infrequently, the patient complained that my tip is too rigid. I cannot move my tip, so I feel so uncomfortable. So when you have to create a very high tip with coastal cartilage septal extension graft before surgery, you have to explain to the patient that you will experience the rigidity of the nasal tip. It's very important explaining this kind of complication beforehand. But this patient was couldn't tolerate the rigidity, so I had to remove the septal extension graft. So for the tip height achieved by the surgery, I lost the tip height. And I studied the changes in nasal tip aesthetics over time following tip plastic. So whatever technique you use, there's always some degree of loss of tip height. No matter what you use, even though you use septal extension grafting or with or without tip grafting, I think you have to expect just a little bit of the loss of tip projection, and you have to explain the patient that 1 month result and 1 year result will be different. So as you can see here, the about 6 months post result was pretty good. About 2 years, there's a little bit of loss of the tip height. So I think this is the reality of the grafting, rhinoplasty. So in summary, the septal extension grafts in my hand, it's very, very powerful and effective in tip refinement, especially for the Asian patient who were in big demand for the substantial amount degree of the tip projection. But you have to understand the dynamics and caveat and complication very well. And you have to apply this technique in well-indicated cases. So you should understand, you should have thorough understanding on the dynamics and pros and cons of this grafting technique. If you use this very well, you can become a very excellent rhinoplasty surgeon. Thanks for your attention.
Thank you very much, Professor Jang. Now I think it's open up for the question and answer. Dr. Lehan, can you
Yeah.
moderate?
Yes. Thank you very much, Dr. Yang for your very comprehensive uh, explaining about the using the septal extension graft. The septal extension graft is very important. It's something like a revolution of the Asian rhinoplasty, and Dr. Zhang is one of the first pioneer who used the septal extension graft in Asian country for the Asian people. So it's very important. And today I hope that our attendee will have many questions to Dr. Zhang because he is uh, really specialist using the septal extension graft. Please. In waiting for the, I didn't see any question. So in the waiting for the question from the floor, I have a question for you, Dr. Chang.
Okay.
Yes. We know that the septum of the Asian people deviated in maybe 50%.
No, I see.
So, yeah. So when you perform the septal extension graft, you have to fix the deviation. So
Oh, yeah.
your indication for the septoplasty before you perform the SCG.
Yeah, so if the patient has a functional issue, if the patient complain impaired nasal breathing on one side, I think before going into septal extension graft, we should be able to correct the septal deviation first.
Yes.
The deviation in the mid septum, but I found that most of the septal deviation is secondary to the bony deviation. So you should be able to correct the deviation of the perpendicular plate ethmoid or vomer. Then you resect some cartilage in the middle part of the quadrangular cartilage. Then in most cases, you can correct the septal deviation well, but the functionally and aesthetically, the most important deviation of the septum is caudal septal deviation.
Yeah.
So before placement of the caudal septal deviation, I use many different techniques, but the technique I like most is, as I showed in my lecture, using bone to straighten and strengthen the caudal septum. Or I can use cutting and suture technique. And sometimes the placement of the septal extension graft side by side, septal extension graft itself can correct the caudal septal deviation. And if the dorsal part of the L-short is straight, you better not to separate the plateau from the septal cartilage. But if the those are part of the septum is deviated. What I'm doing is I usually separate the upper lateral from the septal cartilage. I place the similar techniques applied to the grafting, bone grafting or thick cartilage grafting as a spread grafting, and those should be done. But again, if you are planning to place a extended spread graft, you don't need to place additional spread graft. So usually combining this bone grafting and spread grafting and pattern grafting, you can easily correct septal the septal deviation. But in worst case scenario, we can apply the concept of the modified extracorporeal septoplasty. And then when we design the extracorporeal septoplasty, we intentionally create a new answer which has a higher dimension, especially at the chordal septum. Then we can get naturally protecting chordal septum. Yeah.
It's okay. Yeah. So thank you. And we have a question from Amanda Tan. If we use it in do you when you use the septal extension graft, you always suture the septal extension graft to the corner end of the septum? Do you suture it more to the anterior nasal spine for the best stabilization?
In most cases, so if I have to apply the end-to-end type septal extension graft, I think the major support comes from the bilateral extended spread graft and end-to-end connection with the chordal septum and small buttress graft-like things in the inferior part. And actually, I prefer the stabilizing the inferior end of the septal extension graft using the soft tissue around the anterior spine. But sometimes if I really want very strong support connection, I make a hole as I demonstrate in my lecture using drill or towel clip. But still, if you have a little bit deviated looking end-to-end type chordal septal extension graft, you can press one more small graft, which may make the base portion wider, but it can give you little more symmetry and stability on the chordal septum. So I think that in the base portion, you better have a little more thicker than this the upper portion. So your chordal septal extension graft is ideally should be even thickness, but if you cannot create a well-balanced, well midline positioned graft, you can make just extension graft which has more wider base. Yeah, it gives additional stability. So in number of cases, among my end-to-end type septal extension graft, I usually place one more additional small piece of side-by-side additional extension graft to the end-to-end type septal extension graft.
Okay. So we have to consider about the thickness of the graft, not to block the airway, right?
Sure.
Yes.
But in the end-to-end type, we have enough room in the membranous septum. So I think that if you think it's too thick, but usually if it's quite symmetric on both sides. My observation is that it does not induce any functional issue. Yeah, it can be a little thicker
Yeah.
than your native chorus septum. Still, if you can secure a symmetric nostril size on both sides, it usually causes no functional issue. It's my observation.
Okay. Thank you. One question from Dr. Huy, Vietnam. He asked you that he saw you use mostly the uh, costal
Rib
cartilage
cartilage.
or the
Yeah.
rib cartilage
Yeah.
for the septal extension graft. But when we use costal cartilage, we have to put the patient under general anesthesia. So can we avoid to use a costal cartilage replaced by ear cartilage, and we associate it with other biocomparable material, for example, PCL, TNL, and what is the best way to have the safe the SEG?
Yeah. Okay. I'm not saying that coastal cartilage is the best material. The reason why I prefer using coastal cartilage is if I get coastal cartilage, with one coastal cartilage, I can use it on the septum and tip and dorsum everywhere
Hmm.
with one coastal
Okay.
cartilage, because
Yes.
I don't like to use synthetic implant for those augmentation. But if you familiar with those augmentation using silicone or vortex, you can address the dorsum with the silicone or vortex, and you can use ear cartilage or septal cartilage for the septal extension graft. But I think the thing you have to understand is that generally the Asian female patients, the septal cartilage is extremely thin and weak. So generally,
Yeah.
it is not suitable for
Weak
septal
and
extension grafting. Yeah. And also, yeah, if you want to use your cartilage, you can apply the technique I already mentioned, also strengthening and straightening the
bio.
curve of your cartilage with the bone grafting. But I'm doing many revision
Oryx.
cases, especially shown nose. I found that the your cartilage does not have enough strength to withstand the contractile force of the skin, soft tissue envelope. So that's why I prefer coastal cartilage. But yeah, I think you can use your cartilage. Yeah, but performance may be a little less satisfactory than coastal cartilage.
Yeah.
That's my opinion. Yeah.
Yeah. But in reality, many doctors use the biocompatible
Yeah,
material.
PCL. Yeah.
Yes, to do the
Yeah.
septal graft, and by this way they can do the local anesthesia. But
Yeah,
it's
I know that.
really,
Yeah, Dr. Ed Yap from the Philippines. So
yeah.
he's showing us many good results.
Hmm.
He teaches a detailed way approach how to handle the PCL properly. But I think I'm not in good position to talk about it because um, personally I don't have experience on the use of PCL. I have there's number of cases where I have to remove the cases, but I'm not saying that you should not use PCL mesh. It can be good alternative, but you have to be very careful. Uh,
Mhm.
as Dr. Adia always teach us that you better place cover at one side with at least one side with the ear cartilage. Yeah.
Yeah. Okay. So another question is, you talk about the using septal extension graft for the primary surgery, no surgery.
Mm-hmm.
So
Mm-hmm.
if you use in for treatment the contracted nose, what is your modified technique to
Contracted nose.
yes, in case of
Um,
contracted nose, what you do differently? The same?
Oh, it's almost the same, but in contracted nose, my choice is always 100% coastal cartilage. And in the contracted nose, the problem I encounter most frequently is um, we should be able to release the apparelateral cartilage and you should be able to mobilize it caudally. But sometimes it's very difficult because excessive scar tissue. So in that particular situation, I already mentioned this technique in the during my lecture. I applied dome division technique to bring down the cartilage flap to cover the extended central compartment. But when we close the skin soft tissue envelope, sometimes we cannot close it well. Then we have to give up the desired lengthening of the nose. So we have to bargain. So because the safety of the surgery, I mean the integrity of the skin soft tissue envelope, soft tissue envelope matters most. So if you cannot close the transcolumnar incision, you have to give up a little bit. Okay, so you
Yeah.
have to reduce the length. You have to shorten again.
Yeah.
So the skin is the most precious anatomical component of the nose, which should be respected.
Yeah. Okay. Thank you very much, Dr. Yong Zhang, for your very interesting lecture. And thank you, our attendee, to give us many interesting questions to Dr. Zhang. Because of the due to the limitation of time, our session will be stopped here. And thank you very much, Eddie, to organize this very fruitful webinar. Thank you again,
Thank
Dr.
you.
Zhang.
Thank you. Thank you so much.
Yes,
Yeah.
thank you very much, Professor Jang. Thank you very much, Dr. Lehan, for this session. And also, many thanks to all the participants for staying up till late these hours for this webinar. So just our head starts for the upcoming Nose by Fest, where we're going to host it in the nice country of Bangkok, Thailand, July 17 to 19, where, as you can see from the screen, we have most of the international, famous faculty that is coming to Bangkok for this Nose by Facts program. Okay, so as you can see from the key topics, functional aesthetic rhinoplasty, revision, ethnic Asian rhinoplasty, preservation rhinoplasty, nasal tip, and non-surgical rhinoplasty. So it's a good opportunity to learn from all the experts where we also have hands-on sessions where we are going to close our early bird promotions by ending in 2 weeks by end of April. And I just got the note that we only have like about 4 spots available for the hands-on session. So for any participants who are interested on a hands-on, kindly register on our website, www.feds.my. So without further ado, thank you very much, everybody, and good night.
No, thank you.
Yeah.
Mm.
Good night, Dr. Jang.
Professor Jang.
Thank you.
Yeah.
Bye, everybody.
Thank you.
Goodbye.
Thank you very much, Professor
Thank
Jang.
you.
And
Goodbye,
Professor Jang, can
Eddie.
you hold on for a while because
Oh, sure.
there
Yeah,
is
yeah.
a brief discussion on the upcoming
Oh, sure. Yeah.
hands-on sessions. Yeah.
Mm-hmm.
Please hang on for a while. Yeah. Dr. Montri, can you hear me?
Montri is here.
Hello.
Yes. Okay,
Hello,
Professor
everyone.
Jang, Dr. Lehan, this is Dr. Montri.
Montri,
Hi, Dr. Montri.
my friend.
Hello.
Hello.
Yeah.
Hey. Good
So,
evening, Dr. Jang, Dr. Lihan. Okay.
Hi.
And
Yeah.
Dr. Montri is helping us to select for the hands-on session. And maybe there are certain questions that Dr. Montri would like to ask Professor Jang for his type of specimen for his demonstration. Dr. Montri?
Can you open your video, Dr.
Yeah,
Montri?
just a moment, please. Okay. Hi, everyone.
Hi. Hello.
Nice to meet you online.
Nice to meet you. Yeah.
Okay. Because this evening we just talking with Dr.